Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flow podcast.
Welcome, everybody. This is the Life of Flow podcast, episode number 1005. And we are today very happy to have a super cool dude, good friend for so many years, and now friend of the pod, Dr. Michel Reijnen. Michel's a vascular surgeon, and I'm going to massacre this, but it's a Rijnstaten Aangen, the Netherlands. Maybe I said that. Let's say
sure everyone in the Netherlands is cringing right now.
Passable enough. And also he's a professor now also, which was really cool. That was new to me. He has been, which is funny because it's been like 6 years, but he also has a position as the professor of imaging and innovation over at the Universiteit Twente, which, by the way, was a soccer team where one of the biggest soccer players in Costa Rica, Brian Ruiz, played too. So big people are in the University of Twente, Brian Ruiz and also Michel Reijnen. Anyway, Michel is an awesome dude. We had a great conversation. We got very derailed because I figured out there's new sound effects on the soundboard that we use to record, and I had a lot of fun while using them. But anyways, I think you guys will enjoy this conversation, and I hope you stay tuned for the next few minutes. Bye-bye.
Vamos. The following podcast is not relating to my teachings and work at Del Cedar Medical Center and is for entertainment purposes only.
Oh man, it's taken us a couple of tries to get Michel.
Failure.
Yeah, but listen, there's some responsibility because this man is hard to catch. So we've got some shared responsibility here. I want to say when we first started talking about doing this podcast, I made a list and Michel was on the first
100%.
5 people that we wanted to talk. Here we are, show number
10,000.
We've been at it for are we already at a year or over a year?
We started in September
of last year.
I think so.
So we're a year. So for our anniversary, we've finally been able to get you here.
The legendary.
Yeah. And so man, it's such a fun journey, you know, the whole meeting and the going on the road and putting these circus shows of scientific and I guess non-scientific value bring a lot of great things and at the same time a lot of burden and I guess we can dive a little bit more into that. But one of the very things that I love about this is that along the way you realize that there's people in very different places of the world that think very much like you. It's a bit of, almost like what the internet has done, right? With digital tribalry, where, it doesn't,
you find your tribe.
Yeah. But, before you were born in, wherever in Guanacaste, Costa Rica, and that's all you're going to ever know.
Yeah.
Whereas now, you're born, but you're born into the world and you'll find the people that you align with. But when you're on the meetings and flying and going to different countries, in a way, it's very lonely, right? You're in a hotel room. You don't necessarily know people. You don't necessarily know the place. But when you see a smile across the room and it's, this very warm, very kind human that you've created a friendship with, it makes the trip worth it. And Michel, I put you up there.
Well, thank you, Miguel.
On a short list of people that I look forward to seeing, because I think I have a list of people that I hate seeing that it's probably 5 times longer than that other one. But man, it's so good to see you, and you're always you have a very calming effect, and
well, thank you, Miguel,
to the table.
Thank you, Miguel, because it's great to be here with you guys. It's always great to see you. I'm so glad that at least I was in your top 10 list of invitees, and I'm very sorry that I failed all these times for various lousy excuses, as you know.
Well, we failed you technically last time.
Yeah,
so
we were like, how do we set this up again?
Yeah, you were ready to go, and it was too early for us, I guess. we couldn't get our shit together. But Michel, let's kick off the conversation. What the being on the meeting circle has brought to you throughout the years. I mean, I'm sure that if you go back, it's probably been 10, 20 years that you've been flying around the world to share your knowledge, which we're all so blessed that you do, because you've taught us. I mean, your papers have taught us so many things, and we've learned from you. But tell me a little bit of what that experience, as you look back on 20, 30 years of doing this, what has that brought?
It has brought a lot, and it has cost a lot as well. I think all these travels brought me a lot of friendships. I met so many nice people all around the globe. Some of them really became friends, in which I'm in regular contact, which I do projects together. And when I see them, we also have fun. On the other side, it costs you a lot of time, a lot of efforts. It's not just the traveling, it's not just being away from your family for all this time, traveling back and forth in the weekends. It's also a lot of time preparations. All these presentations take a lot of time to really prepare. When you're there, you can do a good presentation that is meaningful for the people who are there. So it costs a lot, but it brings you a lot as well. And I think when your network grows, it also gives you the opportunity to do more and more meaningful research, because you can really collaborate with the people that you like. And I think that's an essential part of doing research, that you work only with people that you like and that you can trust.
Yeah, that's key.
So if you look back, has there been any time that you've gone to a place and it was initially for work, and you created bonds and friendships that led you to then say, I'm going to come back and I'm going to do something fun. I'm going to maybe bring my family and visit this place again, or learn a little bit. Was there any personal journey that you've done in that sense, that you've taken your family with at some point?
Well, it's a kind of an open door, Miguel. You know that Hendelat is close to me. I've been there from the beginning.
I know it's a loaded question because I know the answer.
Yeah.
You know
You
the
like
answer
teeing it
already.
up.
So
You like me, right?
I know,
it's a
but
too easy one.
Yeah.
I know that, but I know. I
Yeah.
want you to tell us the
Yeah.
story, because there's some pretty
And I think,
stressful stories attached to.
oh yes, but I think Hendelat was a great story. I've been there from the early start, I think. And what I've seen there is that it grew very fast. But regardless of that, the attitude of the people remained the same and different from all the other conferences. It's much more like a family reunion than a real conference. So people are there to connect, to learn, and also to discuss with each other, not only medical things, but also other stuff. So the connections that are created there are really amazing. And I think it's always special to go there. And as you know, I brought my family last time. My wife was sitting there in the middle of the cells of the party with a broken ankle. But she still had a great time.
Did she break her ankle in Mexico?
Yeah.
Oh, yes. Yes, she did.
Yeah,
Yeah.
he dragged her across the world
To
to
break
this
her
beautiful
ankle?
place in the world, and then, she broke her ankle.
Yeah.
God. What's like the most fun Hendelat story? How long have you been going to Hendelat, Michel? How many years has it been?
Ooh, when did it start,
Probably
Miguel?
a good 8 or 9 years.
Yeah. What's the most
Yes,
fun
yeah.
Hendelat story?
Ooh.
Oh, I don't know. For me, they're all blurry. I don't know that I have I don't know that I have one single one. They all kind of blur into one thing. For me, the big story is just that it's the camaraderie, the fun, the also, when one day you're at VEITH and you're giving a 5-minute presentation, that you get off, there's this kind of taste in your mouth that, does anybody really care about that? I mean, my 5 minutes of fame that then have 30 seconds of discussion and on to the next thing. It's like speed dating.
Yeah.
Versus this one where you see these people actually taking notes, and then you do a workshop and it's like, people standing around because there's this absolute interest in learning and then being able to perform at a better level. That's, I think, the huge difference that I foresee in it. I mean, I don't know. That's just Hendelat. I guess it's regional. I guess it's just a culture that we've tried to infuse, and the way that people come to it. We're going to Costa Rica next year. Did you know
I
that?
know. Yeah.
Okay.
Love the company.
So I hope that it's already on your books, because I'm gonna make it as epic as possible, because I feel like now it's like as a
Yeah,
Costa
You
Rican.
have to. Yeah.
Yeah, I have to
Yeah.
shine.
It's a good
So
entry.
as you
Yeah,
know, every
yeah.
Hendo lot is well remembered by its party.
Yeah,
So I'm
Yeah.
going all out.
absolutely.
Oh yeah.
Oh yeah, I'm gonna get a multi-level club,
Oh
and
my
I'm gonna
god.
close the club down. It's gonna
Really?
be big. Oh, it's gonna be
And
big.
that's why all these stories get blurred.
Exactly. And that's how, like, when you ask us the funnest
Yeah.
time, you have no idea. You're
Yeah.
like, I just know I had a fun time. I just don't remember
I
much.
remember
but-
Ross. I remember Ross pulling out the
The trumpet.
Yeah, and just like jamming. I was like, wait, where am I?
Jeffrey Ross, if you don't
Jeffrey
know
Ross.
him, is a really nice vascular surgeon from Houston.
He's a podiatrist.
I'm sorry, podiatrist, sorry,
Yeah.
from Houston. He worked with us in vascular surgery at Baylor, and an older gentleman,
Yeah.
white hair,
Shorter.
very short,
Yeah.
and the mariachis come in, and it's this right, and everybody's like clapping, and the tequila starts running, and all of a sudden I see him just kind of like bugging this little fat Mexican dude. And I'm like, what is he trying? Why is Dr. Ross being so annoying?
Yeah.
And the guy's like trying to play his trumpet.
Yeah.
And then he's like touching his shoulder. And I'm like, what is this guy doing? And then eventually I see, and obviously, by the way, Jeffrey has no idea how to speak Spanish.
Yeah.
And I assure you that the trumpet player
El
from Mexico
trompeto.
had no idea how to
Yeah.
speak English.
Yeah.
But they start kind of going back and forth. All of a sudden, I see Ross wiping the dude's trumpet
Yeah.
on his own shirt, and then puts it on his mouth and starts going. And these mariachis went nuts.
Yeah.
They were like applauding, and everybody just lost it. It was really fun.
That was fun.
So we've never invited him again. That was a fun time.
Yeah.
That was a fun time. On the topic of the time and the investment of time, you kind of painted a picture of there's this really good part of it, and then there's this really not so great part of it. What is it in your mind that is the most taxing about being part of a speaker circle?
I think the most demanding is being away from home so much time. I've been in the airplane, particularly on Saturdays, that I've been thinking, why am I doing this? Who am I serving? What was the purpose? And why am I missing out this weekend again? That happens too much, and I really slow down in the number of conferences that I visit. In the past, I went to quite a few, but these days I really slow down and I pick more the ones that I think are really valuable for me as well.
Do you feel that this was the most perspective, or tell me, did the pandemic have in any way, shape, or form
Oh, yes.
an impact
Yeah.
on helping you kind of reset that perspective?
Yeah, the pandemic helped because the pandemic stopped everything, and it gave you time to reflect. But also, when the years are coming, you get a little bit older, you start thinking differently. The urge of the fear of missing out is gone. I'm fine with it when I'm not there. And that used to be different when I was younger.
Yeah, how was the impetus to innovate and do research? Has that changed at all with the more time you have? Going to less conferences?
No, not really. Because during the years I got also another appointment at the University of Twente, so I got kind of a double job. I worked first 4 days in the hospital and 1 day at the university, and this opened up a lot of doors for innovation for me, because I got dedicated time to really try to do some meaningful innovations.
So when did this start? Tell me a little bit about what that project is and what it allows you to do.
5 years ago, 6 years ago,
Okay.
something like that.
Okay.
I did a lot of research, like forever, like when I was a resident. But then I think a year, 8 ago, the board of the hospital came to me and said, "We want to make you a professor inside our hospital, which is not a university hospital." And he was exploring that, and he himself had a position at the University of Twente, and so it worked out that I got a position there too. Which means that I can now work with other professors, other faculties, and do some research focusing mainly on imaging of flow in the arterial system.
So does this, just from a practical standpoint, means that the University of Twente it essentially takes a fifth of your salary over from the hospital? Like they pay that
No.
little chunk, or
No, the hospital pays it.
oh,
It's
so
the
the hospital
hospital.
keeps doing it, but
Yeah, and it's a little bit
so
more
who
complex. It's
so is the
divided
hospital
inside the hospital. There's
who's
three
interested
stakeholders.
in
Well, the hospital is interested.
so what's the hospital's interest in having you outside of the operating room? Is it more of a they like the recognition as a program? Like what are their what's the upside for them? Because I'm in America where everything is about the money. So
Yeah. Yeah, this
so
is
trying to
he's in
understand.
the Netherlands. It's a community thing,
It's
the
it's
greater
it's a
good.
bit different than the Netherlands. Yeah. Now we it's about the willingness to be a top clinical center. So you need to do more than just production. So you need to be upfront at innovation, at research. So it's production on another level.
What do you think what things are meaningful to you as far as topics to solve, questions to solve? Like what's piquing your interest right now?
There's two things that are particularly of interest for me. I think with our ways of diagnosis diseases and follow up, we stick to relatively old-fashioned modalities. That's the main reason that we started looking at flow imaging. When you look at atherosclerosis, but also aneurysm formation, at the initiation of the disease, flow plays an important role. So when you get flow disturbances, particularly at bifurcation, for example, you get areas of low wall shear stress, and what you get then is that the endothelial cells will disrupt, and then the entire process will come. When you look at how we are looking at our patients and look at functional imaging, the closest to functional imaging is a duplex ultrasound, which is only giving you an estimation in one direction of flow speed, which is really nothing. And then we have some anatomical data as well with CTs and MRs, but we're 2024 already, so there's a lot of different things we can do. Then MR is one of the options, MR flow imaging, which has its drawbacks. It's particularly very expensive. So we're looking at ultrasound techniques to perform flow imaging in both the superficial but also the deeper arteries. And it seems like we are achieving that goal. We can now really test patients with stenotic disease, with aneurysms, and image the flow inside these arteries during the cardiac cycle, which is a great achievement.
So you're talking about invasive ultrasounds
No, non-invasive. Non-invasive,
Okay.
yeah. So the difference with regular ultrasound machines is when you look at the regular ultrasound, the image is built line by line, which limits the amount of frames you can capture per second. We use plane wave ultrasound, in which you can exert all the ultrasound beams at once, and that way you can go up to 10,000 frames per second, which enables you to really track particles in the bloodstream. In the deeper vessels, we add ultrasound contrast agents. But both are basically the same. Either you track speckles or the contrast bubbles.
So what of all this is already out there? Is there anything out there, or is most of this?
No, there's some publications out there. We published quite a few. We have recent 2 PhD defenses on this. So it's out there. The only problem right now is that the technique is being done on a preclinical machine, so it cannot be implemented yet in clinical practice. And then the most important thing still is that with all these flow imagings, you can imagine you've got a cardiac cycle, you've got all these flow imaging, and then you can calculate certain parameters like complexity, vorticity, wall shear stress, etc. But we really don't know where to look at in which phase of the cardiac cycle, which is really decisive for progression of disease. And that's really the challenge for the future.
Any idea how we're going to be able to use that information? Say you identify an area of high risk for developing disease, how we'll be able to act upon that data?
Well, for the future, I foresee when we do know which parameter are decisive for progression of disease, that you can also make a transition to more reliable CFD methods. So you can do virtual stenting, for example, to see which stent you need for which lesion and which would be best. But that's certainly 10, 15 years ahead of us.
How big are these devices? Are they just going to be handheld ultrasounds, or is it just look different?
Well, it's now a programmable preclinical machine, so it's rather big. There's one clinical machine that could do it. We'll start a conversation with that company soon to see if we can make that transition to a clinical machine.
You know, we've been doing a ton of pedal hemodynamic work with ultrasound, and in trying to understand, you know, what the differences in pulsatility of monophasic waveforms, and worked a lot with Jill Somerset, who put together the pedal acceleration time as an option. And now in the world of arterializations, we're also looking into the hemodynamics of what happens with ultrasound as the venous plexus converts and transforms, and the Lejar's plexus becomes arterialized. And I'll tell you, we are investing a significant amount of our daily time noting every single parameter, getting all the databases, figuring out how to implement this in a functional way, how to create objective performance goals, how to decide when to reintervene or when not to reintervene, or when is there a more neuro issue than a neuroischemic, or a more ischemic issue. And because, you know, obviously the diabetic foot problem is going to be overwhelming in the next 10 or 20 years. Do you foresee this particular technology also being of applicability for that sort of very distal territory of the foot, or do you believe this is more for proximal aortic disease management?
I'm not sure. We have not tested in the below the knee vessels yet. I think it should be feasible. The problem there is when you look at ultrasound and you have a lot of calcium, which often is the case in the diabetic patients, you get into trouble. So I foresee that we get troubles there. Yeah, but there's a lot of other technologies that are evolving for measuring perfusion.
Okay, no, but that's good, because I just wanted to make sure that all the work we didn't go to crap because of better ultrasound.
No,
We'd worked 5 years, and then we published this article, and then Michel published one the next week that says all this shit is irrelevant.
Nice try.
My 20 new ultrasound, you just put it 1 meter away from the foot and it gives you everything.
I smash you.
No.
I can
sorry.
see a meme, a David and Goliath meme, just like
I would have loved to do that, Miguel, you know.
Well, listen, to be determined, TBD, TBD, life goes on.
Yeah, so that's one.
The other one is obviously SEC management in conjunction to vascular aneurysm treatment. What I find intriguing about aneurysm treatment using stent grafts is that, it was introduced in the 90s, as you know. And when you look at what happened in these 30 years, well, the stents have improved. But other than that, the technology remained about the same. And we're still putting a stent with some material around it into the artery. And interestingly, we've been debating about complications of that strategy also for these 30 years. And nothing changes. So I think we need to do something else for some people. And I think active SEC management is one of them, besides adding fixation to the neck. I think with, for example, Aptus, there is an improvement in some patients. Needs to be defined who needs that and who not. But the other thing is SEG management. And well, as you know, I've been involved in the rise and fall of Nelix.
Yeah, I was going to say it's not necessarily fair to say that we haven't been able. I think we've tried, but a lot of stuff just doesn't work, right? Nelix was one of those.
Oh, there's a whole segment of V about that, and the first presentation was none of this works. That was the first one. I was like, nothing that we do works.
That's why we're lacking yet.
Yeah,
exactly.
Yeah.
Yeah, you know, we learned a lot during that journey from Nelix. The reason it was picked up so fast and so aggressively is that people realized that we need to do something else. Because it's annoying to still discuss about are type 2s dangerous or not. And we will continue to debate that when we remain doing the same. And I think there are some technologies for active SEC management that are in development. Shape Memory Medical, for example, has done their first human trial already, is doing an FDA trial now, in which the aneurysm sac is filled with polymer plugs in conjunction with a regular EVAR. I think that's a good strategy, although it may be difficult to get these plugs in every place. But I know there's also some
It takes a
uh,
lot of plugs.
a lot, yeah,
A
lot.
lot.
Yeah, we did I don't know if either of you were around that, but we did a live case for Hendelot actually from Houston Methodist, and it was a 2-hour segment, and
1.5 hours of just shoving plugs into the thing.
yeah, I'm sorry, it was like really dumb. I mean, I don't know, it was very interesting, but
It's just the
in
delivery
the back of my
mechanism right
mind,
now.
I had never done it.
Yeah.
And so, the professor comes on and he presents the case and he's like, oh, we're dealing with these type 2. And I've already pre-cannulated the endo leak. So he was already where he had to be.
Yeah.
And then he's like, and now we're going to put the polymers. And then this whole thing, and then pushes it in, and then we're looking at the screen. And he's like, there it is. And there's this little thing that just kind of floated. And then I'm like, okay, and now what? He's like, now we're gonna load the second one.
49 on more.
And they did that, and
Yeah.
we're like, okay, we're gonna come back and do it. So we come back 20 minutes later, the guy's mounting more. Then we come back 40 minutes later, mounting more. An hour later, mounting more.
I relate to that. Yeah.
And I just thought, you need to do this like they did the wieners back in the day, right?
What?
Yeah, like the sausage wieners, right? Like when they're all connected.
I love where your brain goes.
Just like when you do a hot dog, they're cut, right? But those hot dogs actually are all connected.
Oh, you mean, okay, so they need to be connected.
Like just put 100 of those and shove them in a way that there's a pusher that keeps pushing, because that's the dumbest idea I've ever heard, to load everyone.
It's an FDA thing.
No, but it's
uniquely.
Yeah.
No, they got
maybe
five in one cartridge. But when you need to do 100, you need 20 cartridges.
Oh, maybe a gun, right? Like that you just go like load, rack, load, rack, load, rack, load, rack.
They don't do guns in the Netherlands.
But this again is only the start, guys. I know the company is working on some very innovative strategies to get these plugs in faster and easier. But there's also some other companies like Vascular that's working on a dedicated device. There's a Dutch company as well that has a liquid polymer that can be injected. It's tested now in the first human case. So a lot is going on at this area.
Yeah, you know what I've thought about? When you do a rupture, one of the things.
Wait a minute. Let me try something. What? So then we came back to the case, and we were like, "Say, so what are you doing now? An hour later?"
Okay, I'm gonna move that over here, and you're not gonna have access to it. You're not allowed to do more than 2 chirps per episode.
I thought that was good.
No, okay. Podcast.
Yeah. Yes. Rim shot.
What?
CJ, I realized that. Rim shot. I've got
Stop it.
Sound effects here.
Stop it.
All right, let's get serious again.
Okay. So one of the things that happens when you get ruptured aneurysms is that they keep bleeding from the lumbars.
No, that's because maybe you can explain that.
I've thought about pushing something. I've thought about sealing it, leaving a catheter, and then injecting thrombin. And somebody told me that was stupid.
Yeah. So Lucas, can you explain me something? Because I really don't understand this. When I do an open aneurysm for rupture, and it goes well, and then the patient after surgery doesn't go well, has got to rebleed. It's always a lumbar, correct?
Yeah, always,
yeah,
100%.
Yeah.
So then I comes in a rupture. I do an EVA case, and the lumbars never give a problem. How can that be?
They do give a problem when they do give a problem. Like when patients get abdominal compartment
I hardly
syndrome,
ever have
they
to
die.
open up an abdomen for a type 2 endoleak after an acute case with EVA.
What about for abdominal compartment syndrome? And what do you think abdominal compartment syndrome has something to do with, volume from those lumbars filling up the abdomen?
I don't know. I
would think that's something.
When I do an open surgery and I leave the lumbars open, I get into trouble. And when I do put in a stent and I leave them open, usually it goes fine. It doesn't make sense to me.
Yeah, I've gotten into trouble with abdominal compartment syndrome. I've had a couple of patients from it, and then you open the belly, it's a bloodbath. Yeah.
So what is it that you're up to in that? Like, can you share anything of what you guys are developing at this point, or what is your research team doing?
My research team is not doing anything on that field.
Oh, okay.
But there's a company in the US that works on a dedicated device to prevent endo leaks called Vascular. It's a dedicated device that will fill the aneurysm sac as well. And there's a Dutch company that has developed a liquid polymer that can be injected in the aneurysmal sac also to avoid type 2 endo leaks. And I think there's a French company as well that has an EVA device with fibers on the outside that will thrombose the aneurysmal sac. So there's a lot going on.
Isn't there, and I'm not a big aortic guy, so I don't really keep up to date, but isn't there now medical therapy? There's a drug approved for the FDA that
For type 2 endo leaks?
no, for aneurysms.
I know that there's a company coming up, but that's like prevention.
Yeah.
Yeah.
So like if you have a small dilation, you
Yeah.
can start taking this and it decelerates the progression.
Yeah.
So then we're talking about a topic that's going to be an absolute.
I love how you hate anything aorta.
Well, it's just going to go away.
You're like-
There's nobody's going to have an
you're like,
aneurysm in 100
fuck
years.
aorta. Everything
No.
only below the ankle. That's the only thing I care about.
Humans should just be a head and 2 feet.
With an ulcer.
Can you imagine just head with like 2 feet walking around? That would make life.
Now I know your kinks.
but no, really, I don't know that aneurysm is going to be that important in the future. And you know what? At least I guess maybe, okay, I'll put it this way. I don't see my community, my Hispanic old ladies and a bunch of indigenous people with aneurysms. They just don't have it.
No, it's just an interesting topic.
They don't.
There are many interesting topics.
No, I get it.
Old
but
Hispanic old ladies are not.
I understand, but okay, if I was going to put money, all right, let's say it's Shark Tank, and I'm a multimillionaire, and I just heard Michel talk about 2 things that he's interested in. I would put so much more money on his ultrasound thing than on any other idea he may have for aortic disease. Because what did I hear the other day? Some idiots trying to make an endograft that you could put from the brachial artery.
Yeah, they did.
Yeah,
I don't remember who it was, but
I do.
What is it? Is it your company, man?
No,
just go and close it. Like what?
No.
Really? What are you
but I
going to
know-
do with an endograft from the arm at this
I know
point?
about that company, but still,
I mean,
people think there's a
please
need
go
for
against-
it. I don't see
Go
it.
against me. No, but I'm happy to have a good discussion open. Do you think there's a purpose for an endograft from an arm?
if it's 10 French, yeah.
So why
Sure.
wouldn't you put a 10 French endograft from the groin?
I think it's because of the mechanism of deployment. Is that you have to invert it? Is that
But I don't want it to be small, because we know the smaller they get, the worse the quality of the endograft will become. We learned our lessons there.
You compromise the quality of the PTFE unless you
Yeah.
come up with a new PTFE.
I think for this one, it's that the only thing they're changing is the deployment mechanism and the location of it. I don't know too much about it.
Interesting.
I'm all for innovation. I'm all for crazy ideas. I want a lot of crazy ideas.
So have you guys heard? This was an interesting conversation at VEITH. So this group of people reached out to me that so essentially when you look at PTFE, we think of graft, but PTFE is essentially a molecule that it's almost ubiquitous in every medical device, and it's part of the coding of every wire. It's part of there's like Teflon based coatings and a bunch of other stuff, right?
Yeah.
Well, apparently there has been more and more raising data that shows that a lot of these particles are ultimately ending up in your body and that have accumulated and are carcinogens.
In the surgeon or the patient?
In everybody, like microplastics.
Oh yeah, microplastics.
Like the
Yeah,
world.
Yeah.
Okay.
Yeah.
But this is particularly one that is becoming a problem. And so this company, hear me out, this company that is coming from the energy field is not even like in the medical device. They're already developing the substitute of PTFE because they believe, listen to this, that PTFE is going to be illegal within 10 years. Everything we have, if these guys are right, everything that we use is going to have
you knock on a company making an aortic graft that comes from the arm, but you think like it's a great idea that somebody's going to replace PTFE? Hide that.
For everything.
100%.
So we're going to have different codes, different sales for the boats,
Everything.
different endografts, everything.
Everything. Listen, the amount of microplastics in your testicles today has been scientifically shown. There are people. Why are you guys laughing about this? There's a group that related carotid disease to microparticles of plastic.
Yeah, I saw that.
You should never drink a plastic cup ever again.
I try not to.
Just drink water from a glass container.
Yeah, no, I try not to. Yeah,
Okay.
when I get to the office,
Michel, you shouldn't laugh, man. I'm telling you,
I'm getting depressed.
You're becoming RoboCop.
Yeah, when I get to the office, sometimes Jenna, my nurse, she's amazing. She sometimes has like a tea waiting for me, and I was like, "Oh, this is so nice," but she has it sometimes in like a styrofoam cup. I was like, "Oh, you're trying to kill me, aren't you?"
Really, guys?
So do you drink it?
Yeah, I drink it.
I think I really think there's something. I mean, listen, some people are big on this. Like some people don't even have Teflon. Do you like Teflon
I don't do
to cook?
any Teflon.
Why?
Yeah, because I think it's gonna give me cancer in my balls.
Exactly. Well, exactly. So what I'm saying is, I mean, there's a lot of, there's a lot of big pockets trying to avoid us from learning this, but there's a lot of these substances that we use on a regular basis that we think are incredibly safe.
Yeah.
But they're not. And I think that there's something about this coating material, and it's really hard, and you wouldn't know, because here's the thing.
Well, what's this new material gonna
they
be
blind
made
tested me. Well,
out
I
of?
can't tell you because I'd have to kill you. But the new material won't go to your testicles. And
How sure are you? How do you know?
It goes.
How do you know? And where does it go?
They paid me a lot of money for biopsy.
Yeah, exactly. This is a paid advertisement, by the way.
Plastic-free testicles of America. No, but I hadn't even thought about this. So they gave me gloves, and they essentially kind of blindfolded me to maneuver wires. And so they'd give me a V18, they'd give me a Command ES. Yeah. Then they'd give me a glide wire. Then they'd give me a whatever. Then they started giving me the ones that they had, and immediately, I'm like, this is not a good coated wire. And I can hear them say "fuck," right? But it was very funny because it's so interesting that the tactile sensation that we have with these wires is incredible.
I will never give up my glide wire advantage. I don't care. I will fight to the death.
I love it as well.
Yeah.
I think it's a dumb wire. But the coding, back to the coding. So you want to know what?
It'll be funny if this podcast ends because we have like a rift over like the glide wire advantage. I was like, stop.
It's fine. Listen, I hope that the Terumo, comes and sponsors something and talks to us. And I hope the company with the arm thing comes and sponsors me and brings somebody more intelligent than me to, well, that's not difficult, somebody slightly intelligent that could give us a good understanding of why that would make sense. Because honestly, you're going to have to go to the investors and get investors to support your company. But anyway, I'll just say coding, listen to me, coding is a huge thing. And there's going to be a lot of radical changes on stuff that we don't even notice on a daily basis. And so what I told them is like, listen, for stiffer wires during aortic interventions, I don't think these coatings are that important because all you're looking for is rigidity. And, you want the thing to go up. I mean, as long as it slides. But then for more complex, tactile sensation, torqueability, capacity to move through, and that the wires don't get destroyed every time, that's where it's complex. And, they just said, listen, our thing is just the coating. Like the wire. Yeah,
the wire's a wire.
Is a wire, and if it's hybrid, if it's not, if it's nitinol, if it's not, but the coating is where it's all going to go. And they're trying to do something where they have the next generation coating. I don't know, but I think there's something to this.
Well, I hope your investment does really well.
No, I'm not I tried. They didn't want my money. They apparently are very well funded by energy companies. That's the thing, because I think it's PTFE is also in a lot of the coverings that they do for cables, and so they're looking for the next.
It's in everything.
Okay.
It's in everything.
Yeah, but isn't it financially driven, Miguel? Is it really true? The story that PTFE is so harmful.
Well, I don't know. I mean, there's some good data, right? I mean,
that paper on
So I
carotid
wasn't
disease
joking.
was,
I was joking, but it wasn't. I mean, what they did is they've actually taken a lot of histopathology from human specimens and analyzed the amount of microscopic microplastics
I know,
in these things.
but
And
there
PTFE is
hasn't been a
known to be one of
correlation
those.
directly to cancer. I think there has been some correlation to atherosclerotic disease because I think
Inflammatory.
if I remember, I mean, and you would think that if inflammation is the driving factor, then cancer is right there.
No, there's one also in carotid disease.
The one in carotid is compelling
Because then they took the plaque and then
Yeah.
they analyzed it and they found the amount of
Yeah.
microparticles.
I think before we deal with PTFE, we should deal with string cheese.
Oh fuck.
Miguel loves string cheese, and it's probably giving him
just
ball
cheese.
cancer too.
It's whatever. It's probably full. I mean, the thing, every string cheese is plastic around it.
Exactly. See,
Microplastics and testicles. I'm asking ChatGPT.
So why this?
No,
Why this
there
focusing
is-
on testicles, Miguel?
There is. I thought that there was some data around like sperm count, and Miguel's trying to start like a baseball team.
I'm
Okay, let's move
well,
along.
the thing is, it's going on and on. I mean, I got an entire thing here,
Yeah.
but yeah, I just said, can you summarize it in one paragraph, and then we'll have somebody more intelligent than either of us three to just say what's going on. Listen to this. Listen to this. What do I do now? Can you make it speak?
You have to talk to it.
Oh,
okay.
It would have been nice if ChatGPT
We'll get there someday.
There.
He'll do the podcast for us.
And I can't wait to get started. So what's the game plan?
Can you read out loud that summary about testicles and microparticles? All right. That's
so work
that's exactly it. So Michel, point well taken, Michel. There's probably no risk.
There was nothing. It was a great summary.
Oh my god!
All right. So
what are you up to? What are you up to now, man? What's what are you planning on doing for 2025? Where are you going to focus your energy?
Oh, that's a good question.
Yeah. We're coming toward the end of the year. It's time to start thinking about what we're going to do.
Nothing special in mind. Less meetings, better meetings. Costa Rica for sure. It'd
be nice if you could bring your wife too.
That would be great. Yeah.
We can fracture the other leg.
Just make sure you don't break anything yet.
We'll break the other ankle.
Just invite an ortho guy just in case.
We'll have a foot and ankle surgeon there on site
at
least
for her.
Yeah. No, but the other end, nothing. Not great plans for next year. Nothing special.
What about you, Miguel?
I want to keep doing this. I'm also with you. Less meetings. If I go to meetings, it's because it's a quick turnaround. Part of that is because I'm dissatisfied with the whole meeting circle thing, but also because now I run a business, right? Now I have hope, and every time I'm outside of the office, I'm paying for staff to be there while I'm not there. And so, the productivity of the office hinges on me being there. And so that's a big driver of not wanting to do it more. And yeah, I mean, I really want to knock the 2025 handle lot out of the ballpark because Costa Rica means so much to me. And then the other thing this is really cool, man. You'll probably like this, but you know that Toño and I have this early feasibility company that is called Henderson. And we actually started operations in Costa Rica and we got our first study accepted. So
congratulations.
Yeah, this is a company that essentially has produced an absolutely new graft material that is all essentially
non-PTFE
free.
I see where this is going.
Testicle preserving.
It's all
testicle preserving grafts.
No, sir. It's a very small metallic scaffold, and it's all bioabsorbable. So essentially, the endothelial comes, and then the scaffold of the graft goes away.
The metal goes away?
No. There's small rings of metal.
Okay.
As a scaffold.
Okay.
And then those small rings are connected by a matrix. Only.
Yeah.
It's very porous.
Okay.
So you have to kind of seal it, and there's a little process by which you seal it with thrombing and a bunch of. But then you do the FemPop bypass, and then within months, all of that matrix essentially gets substituted with a very flat endothelium.
Wait, what? Why are you? Is this endo or is this a bypass?
No, this is for bypass grafting.
Oh, this is
the new, because we want to get PTFE out of our bodies, man. No, but really, PTFE has had there's been no evolution in open surgery in
Finally, the
20
pieces come
years.
together, Miguel. The pieces come
You're
together.
really passionate about saving testicles.
You don't want to, save your legs and save your balls. That's the motto of the company.
Yeah.
Save a leg, save a ball.
Wait. So the metal stays,
yes,
but what's connecting the metal disappears.
Correct. No, the matrix that's inside
So
disappears.
what keeps the blood inside?
The endothelium.
Oh.
Yeah.
So if you go back and operate on that shit,
it's a vein almost. It looks like a vein. Yeah.
It's gonna be a shit show.
It's really interesting. The restenosis rates are very minimal.
Really?
They've done coronaries. The crazy Europeans have done already coronary bypass. There's an ongoing study in the US for AB fistula creation, and we're going to do the first fempop bypasses of the world. So that's really cool for 2025. Costa Rica, baby. Pura vida. By the way, I'm wearing my Pura vida hat. Let me get real close to the camera. Costa Rica. See?
I hate this. Please stop this.
I love this.
Okay, we're going to end the podcast now.
Okay. I love now having all these sound effects. Anyway, man, we said we'd bullshit with you for an hour, and I think that we've done a great job at it.
Yeah, we've done a great job at that. Yeah.
Michel, how was your experience? Was this as good as you ever thought it would be?
It was as good as I thought it would be.
Aren't you sad you hadn't done this before with us?
Yeah, more often.
Man, well, we really need to do this more often, man. I love you, and I hope to see you soon.
Yeah, I'll see you in Costa Rica with some cheesy techno music in the background.
And a foot and ankle surgeon.
Yeah.
Would be great.
We cover all our bases. All right, man. Say hi to the family, and we'll be in touch, brother. Thank you very much for doing this.
Thank you for inviting me. It was great seeing you.
Yeah, it was a pleasure.
Pura vida.
Bye.
Bye.